require surgical treatment. So the first thing I'm going to do is just give the results of the screening at combined conferences. And, you know, the only time that orthopedic surgeons are going to see enough CFC kids to be able to write a paper on it is if they come to a conference like this. And so Dr. Stevenson and I came and examined a whole bunch of kids at what was it, the Seattle conference or the, I can't remember which one it was.
It's in Berkeley.
Berkeley, yeah, that's right, the Berkeley. And there were, that was a combined conference, so we saw 1 million kids and Costello kids as well. And then I had a medical student, Ann Sung, who was working with me at that time. We wrote it up. And so this is written up in Journal of Pediatric Orthopedics, and you can get it online. It's one of the articles that's free online. So you can just look it up if you need to. But here is basically the results, and I've put the CFC results in order of from the most common to the least common here. And it starts off with flat feet, which 2/3 of the kids had hypotonia at some point along the line, was seen in 52%. Usually that's something that shows up early, and then as the kids get older, many of the kids lose that hypotonia and seem to be, and instead of being floppy kids, they end up sometimes even being tighter than normal. Poor hand use is something that a lot of people are concerned about. I put that down in instances where I don't see anything that's really wrong with the hand, but for some reason or another the child is not using it appropriately. And so I look for that and look and see if the kids seem a little delayed in their hand use. And that's basically what it amounts to. There's not a lot of anatomical abnormality, but it is there. And then 9 of the 26 kids that we saw had scoliosis that was significant. 6 of them had hip dysplasia. 6 of them had knee contractures, and if you have really severe knee contractures, then that really is going to prevent the child from walking. So that's one of the things that's significant. And then poor shoulder use. This is again is a thing where I examine the shoulder. I don't find anything that's really wrong with it, but the parents tell me that one shoulder won't go up quite as far as another, or there may be a limitation of motion, and it's usually not something that requires any surgery, but it's there. And then elbow contracture, the more I look at the elbow, the more commonly I find it. And normally, you know, a person will be able to straighten out their elbow and maybe even go a little bit beyond straight. But the average child that I saw yesterday, for example, I would guess 70% of them had just a tiny bit of elbow flexion contracture. And that's something that's commonly found in a whole bunch of different dysplasias. This is going to keep coming up, I think. And then kyphosis, which I've already mentioned, and foot callosities are probably more common than 4 out of 26, really. I think a lot of times that's not a big problem. People just learn to shave it down, and then there are some for which it's a really big problem. And then femoral retroversion is something that I saw, I think, 3 kids yesterday with femoral retroversion. But what it amounts to is the knee. If you bend the knee and keep the hip straight, then you should be able to make the knee point outward about 45 degrees and point inward maybe about 60 degrees. That's the normal. If you can't make the knee point inward, then you have femoral retroversion. and it's a turning outward of the thigh bone so that the knee tends to go outward. And the children that have this tend to walk with a gait that's something like this. And that is something that does not normally correct after age about 5. There are many kids that have that when they're very young, and then about 80% of them will correct it before they're age 5. But if it persists beyond that, it's probably not going to correct. And many times, the only way to correct that is to cut the thigh bone and turn it inward, which actually, I mean, it sounds like a horrible thing, but it's actually a pretty simple thing to do with very small incisions, and we usually fix it with some wires that are inserted above the knee and through little tiny percutaneous incisions, and that's pretty easily handled these days. Okay. Hip contractures. Again, if your hip is bent like this, then your posture is going to be thrown forward, and so that's something that an orthopedic surgeon is going to have to be looking at, and if it's severe enough so that it seems to be a real problem, then we have to do something about it, which is usually some form of hip release. And then toe crowding is something that distinguishes. I've never seen that in a Noonan patient. I've never seen it in a Costello, but it's where you have your toes, one over the other and sort of squished together like this and aimed together. And I saw one patient with that yesterday, and I've seen a lot of them in the past. Pectus carinatum and pectus excavatum kind of go together, but basically deformity of the sternum of the chest cage here, and the numbers that we actually saw were we only had 2 of those that we saw out of the 26, and that's a lie actually. The thing is that we were doing examinations in an open room. You don't take off the shirts of people in open rooms, particularly if they're females, and so we probably missed a lot of them that were there. And the only people that really where that showed up were people that complained about it for one reason or another. And then leg pains for various reasons, that I don't always understand, but we'll have people that come in and they say, well, it hurts right above their ankle, and I look there and I don't really see anything that seems to be wrong. And so I'm not all that sure just why the leg pains are there, but there are complaints of that. And then hallux valgus, that goes along with flat feet, and it's basically a bunion. You tend to see that in older kids or adults, and since bunions are really frequent in the normal population, I'm not so sure that has anything to do with Kyphosis cutaneous syndrome. But it is seen more frequently in people that have flatter feet, and so it may go along with the flat feet. Chiari malformation is something that you're not going to find unless you do an MRI. It's an abnormality at the base of the brain where the lower part of the brain actually is not confined to the skull and bulges out that little hole that's at the bottom that leads to the spinal cord. And that can be significant and can lead to hydrocephalus and other problems. And it's also been associated with the development of scoliosis. Equinus, walking on tiptoes, probably more frequent than 1 in 26, but that's what we saw in this particular one. Excessive lordosis, where they have a sway back, uncommon. I don't think I've ever seen more than one in CFC. An external tibial torsion, where the the shin bone actually turns outward so that the foot is outward. So if I would draw a line down the middle of the thigh and a line that goes down the middle of the foot, that angle is maybe 45 degrees. The normal is about 15 degrees outward. And that occasionally requires surgery to turn it back in again. And then internal tibial torsion is pretty uncommon in CFC. I did see one patient with it, but that's where the kids are walking with their toes inward. The vast majority of the kids with CFC are walking with it outward. So that's unusual, I think. And then you see a bunch of zeros in CFC, but things that are found in Newman's and Costello syndrome. And so here are all of these ones where you see just one in out of 26. And the big question then is, does that have anything to do with CFC? And, or is it just coincidental? Because, you know, if you have a torticollis twisted neck, that happens in a certain percentage in a normal population. And many of these, I don't think we're seeing them more commonly in CFC than I would see in a normal population of people. So a lot of these ones are probably not related at all to the syndrome itself. So pathophysiology, this is the mechanism by which one aspect of a disease leads to another. And in other words, if we know the pathology, we understand the disease, we know what's going on, okay? So if you had diabetes prior to the discovery of insulin, you might have called that a syndrome. And you might have said, you know, we don't know why these people are getting up every night and having polyuria, you know, where they're urinating all the time, and they have all of the problems that tend to come together, but we don't know what is really causing this. Once we discovered insulin, then a lot of these became known, and we knew how insulin went on to lead to these problems with, you know, insulin necessary to take care of the sugar. If you don't have the insulin, then you build up your sugar too much, and that makes you urinate too much, and so forth. So then we know the pathophysiology, and to me, if you don't know the pathophysiology of the disease, you don't know how to treat it. You've got to know the pathophysiology first. And so then the question is, with many of these things, what comes first, the chicken or the egg? You know, do they develop flat feet because they are loose jointed, or is there some other cause, you know, that is there? So disease, by definition, is something that has a known pathophysiology. Now, I can't think of any disease that we know the entire pathophysiology. There are still questions about diabetes, but we have a pretty good understanding of what's going on with that. A syndrome, by definition, is something where the pathophysiology is not known, where there are a bunch of related things but we don't know what the relationship is. And I'd submit that cardiofacial cutaneous started off a syndrome, and maybe we should be stopping that now and starting to call it a disease, because a lot of the things are known now. There's still a lot to be worked out, but a lot of the problems in planning therapy still in orthopedic conditions is because we don't really understand the pathophysiology. So pathophysiology, it may be just primary skeletal disease. Okay? So for example, if you have low bone density in CFC, that could be due to just the fact that the bones aren't functioning properly because of, you know, the gene itself, or it could be just because a lot of the kids are sitting down for a long period of time. And if you're inactive, you're going to have a low bone density. So it could be due to that, or there are a number of different scenarios. And the question is it primary skeletal disease, or is it secondary to some other problem, like muscular dysfunction or neurologic dysfunction, or either in the brain or in the spinal cord or in the peripheral nerves? Or do you just have functional problems because of sitting all the time? So instability of the hip, for example, is something that we see in every child that has a tendency to be a sitter into later childhood. So that probably may well be due to functional deficits, or it may be totally unrelated. So growth dysfunction, 2/3 of CFC patients have short stature, and the etiology of that is still pretty unclear. We know that there's a thing called insulin-like growth factor 1, and the modulation of that is part of the RAS-MAPK pathway. So there's pretty good evidence that at least the chemicals that govern growth are part of this RAS-MAPK pathway. And some of the kids may have growth hormone deficiency. Others may be resistant to growth hormone. But there's no way to know that unless we actually draw growth hormone levels on a bunch of kids with CFC. And until that's done, and done in a systematic fashion, we aren't going to really know whether growth hormone is indicated in the treatment of CFC or not. That's something that really, I think, needs to be worked on a little bit. And I looked for articles that have been published on that, and I could not find any. Maybe you know of some. But,
How much has been studied on growth hormone?
That's kind of what our grant is to assess, at least right now, just the incidence of how many kids with CFC are on growth hormone therapy.
yeah.
And how many have actually been documented that have growth hormone deficiency. So that's underway.
Yeah, I think that's something that really should be done, and I'm glad it's underway. Bone density, ERK1 is found to positively regulate osteoclast development and the resorptive activity in a mouse model. So we've got a mouse that shows that ERK1 is involved with that. And of course, ERK1 is certainly one of the MAPK genes. And bone density was found to be diminished in 9 subjects with differing RASopathies. And this was done by Dr. Stevenson, but looking at that, only one of the 9 patients had CFC. So a single patient doesn't give you a tremendous amount of information. So Dr. Stevenson did more looking at it and found urine pyridoxaline breakdown products increased in the urine in 50 patients with Noonan, Costello, and CFC. And 14 of those patients did have CFC. So the incidence of urine pyridoxaline breakdown products means that there's increasing bone turnover. What that means is in the processes of growth, bones are laid down, more bone is laid down, and then bone is also taken away. So if you have a fracture, for example, you get this big bulge of bone, and then eventually that's resorbed down and it takes the shape of a normal bone. And so that's something that has to be done in order to grow properly. But the bone resorption is we don't know about the bone formation. So what's the balance? If the bone resorption is more than the bone formation, then you've got a problem. If the bone formation is keeping up with the resorption, then you don't have so much of a problem. And so I think we still need to know how much bone density loss there actually is. And so whether bone density decrease is a clinical problem in CFC is also unknown. bone density analysis might be considered before bone surgery or in the event of fragility fractures. But I'm not aware of an increased incidence of fragility fractures in children with CFC. They seem to have no more fractures than other kids in the world. So my guess is that it's not a huge problem, at least from the standpoint of fractures. Early hypotonia, low muscle tone and weakness, is a feature of all RASopathies, and it may be transient. It's found in about 50% in infancy, and then later hypertonia may be neurologic in etiology. So as the child matures and there's a tendency for the tightness to show up, particularly around the knees, and a lot of the kids that were floppy tend to maybe even abnormally tight later on. But the floppiness early on is a sign usually of muscle dysfunction. And so one of the questions is there weakness of muscles that's involved with this? And this is a very important question to me. And Dr. Stevenson looked at a whole bunch of patients and found that there was decreased grip strength. And I think you mentioned that paper in your talk earlier. But decreased grip strength in basically all of the patients with RASopathies, and including in CFC, and that's an important finding because these kids are at all levels of function, and still they have decreased grip strength, So there were some biopsies of 6 kids with CFC and Costello, and they had an abnormal fiber size and variability in type 2 fiber predominance. And I'll just tell you that that's very nonspecific. That means there's something wrong, but it doesn't tell you what's wrong. It's also something that we see frequently in functional muscle disease, where there's been immobilization for a period of time, for example. And so that doesn't necessarily mean that there's a primary muscle disease. But it's very important for me to know whether there's, for example, a weak quadriceps. If there's a weak quadriceps, then if I lengthen the hamstrings to try to bring the legs out to full strength, it's not going to be successful. And so if the problem with straightening the knee is that the muscle that straightens it is too weak, then just lengthening muscles that are in the back of the leg isn't going to do the job. And so that's a very important question to me. And I suggested to one patient, the patient's parents, that the child have a muscle biopsy of the quadriceps and really look at that and see if they can find evidence of muscle weakness. So that would change treatment. 4 out of 5 patients with congenital myopathy with excessive muscle spindles, which is another disease, actually. This is not one of the CFC, not one of the RASopathies, but they were found to have HRAS mutations, which is the mutation you find in the skeleton. And a fetus with CMEMS was also found to have HRAS mutation. So nothing, putting together 5 subjects with encephalopathy and lactic acidosis, which is considered what's called a mitochondrial myopathy or mitochondrial encephalomyopathy. Trying to be nuts. Anyway, had mutations in the oxphos genes and but they also had MAPK mutations, 3 in BRAFs and 2 PTPNs. And then 18 MAPK subjects, 7 BRAFs, 6 PTPNs, 3 HRAS, and 2 CRAS were evaluated for OXPHOS, and 2 had lactic acidosis, 1 increased urinary ethylmalonic acid. So basically there seems to be some linkage between these mitochondrial encephalomyopathies and the RAS pathways. And now the mitochondrial encephalomyopathies frequently are involved with mitochondrial genes. They have nothing at all to do with RAS. They're not even nuclear DNA. And then one patient with CFC with the BRAF mutation had coenzyme Q10 deficiency documented, which is one of the mitochondrial myopathy associated enzymes, and it's that patient had substantial improvement following coenzyme Q10 treatment. So the question is, okay, if this is involved with both the muscles and the encephalomyopathy means that it involves brain as well. And these are the 2 metabolically most active and most energy requiring tissues in the body, brain tissue and muscle tissue. And if both of those seem to be associated, then the question is some of the brain problem that kids with CFC have associated with the same thing that is causing a muscle problem? And if so, then there's reasonable question as to whether you could use various, basically vitamins to treat it, because vitamins frequently show dramatic improvements in kids with some types of mitochondrial myopathy. Okay, bottom line, I think there's pretty good evidence of primary muscle disease in CFC, but it's never been really proven. And I think more muscle biopsies need to be done, frankly. If you don't look for it, you won't find it. So chemical mechanisms yielding this muscle disease are also capable of affecting brain function, and orthopedic therapy must take into account the possibility of muscle dysfunction arising both from primary muscle weakness and loss of central control. Central dysfunction is present to varying degrees in all subjects with MAPK disorders, and with cognitive functioning in 42 Noonan patients were deficient only in speed of information processing. So the Noonan patients had much more mild problems. And then cognitive functioning Costello subjects were reviewed, and the findings included mild to moderate disability, increased anxiety, nonverbal skills that plateaued in late childhood and early adolescence, and variation with specific mutations. Now, 6 subjects with Costello also had evaluation for dystonia, and in addition to they have a funny hand that really postures frequently. They had this classic Costello hand posturing problem, and that appears to me at least to be dystonic in nature. And dystonic alterations were found in the face, limbs, and trunk. And the question is dystonia found in other types? Now, somebody showed me some videos of a CFC patient that walked like this. Okay? And that's very dystonic type posturing. That's how dystonic people sometimes walk. And so the dystonia is where there's abnormal tone, sometimes a abnormal posturing of a limb or abnormal posturing of there, and usually accentuated by activity. So that's an interesting thing. This is a patient with actually 2 patients with with posturing of their hand in Costello syndrome, just to show you a little bit of dystonia. And then 28 Costello subjects were evaluated for central anatomic abnormalities, and they found 14 ventriculomegaly, 27 posterior fossa crowding, 32% Arnold Chiari, and 25% of the syrinx. Now, all you need to know about this is that these are anatomical abnormalities in the brain that they're things where the brain was not formed properly to begin with, for the most part, and really significant findings on MRI. So, what do we know about CFC? Well, brain subject imaging of 2 CFC patients showed a lipoma of the corpus callosum and periventricular leukoencephalopathy. The periventricular leukoencephalopathy is what you see in kids that are grown up and become are premature and very premature born, and later develop cerebral palsy. So that's the classic finding in cerebral palsy. And lipoma of corpus callosum, however, is a indication of what we call an error in neuronal migration. It's an error that happens in the early part of brain formation, usually in the first trimester of pregnancy. And then hypoplastic corpus callosum and defective myelination was seen in the other patient. If I look through the literature, I find patients that have ventriculomegaly, hydrocephalus, cortical atrophy described as MRI findings in CFC as well. Now, our findings, we had 19 Noonan patients. 3 of them had abnormalities. One was an Arnold Chiari formation, 1 syrinx, and 1 cervical stenosis. And then 26 of the CFC patients, 1 had hydrocephalus, 1 had a torticollis or a wry neck, and 1 had an Arnold Chiari. So there do seem to be anatomical abnormalities that are more common in CFC than in the normal population. And then 3 Costello's patients had 1 cervical stenosis. And this is a child with cardiofacial cutaneous syndrome, and I'll just tell you that all of this in the cervical spine is water that is filling the inside of the cervical spine, spinal cord, and this should be a dark line that comes all the way down here. Instead, it just rims this. So this is what's called a syrinx, and it can interfere with the function of the nerves way down. And this requires surgical treatment. This patient also has, you see this kind of dipping down here? That's an Arnold Chiari malformation. That's the brain pushing down below the hole at the bottom of the brain. So you're not going to find that out unless you do an MRI, really. And then Noonan, one case study showed an association of Noonan PTPN negative with Charcot-Marie tooth, which is a peripheral nerve disease. And well, that's interesting. I suppose you can have two genetic diseases at the same time, but that's interesting. And we did find chronic neurologic type of pain in 5 patients with Noonan syndrome, but we didn't find that in the CFCs. And 2 case studies showed progressive peripheral neuropathy that are in the literature. And but the peripheral nerves in cardiofacial cutaneous syndrome have never really been systematically studied. To really look at this and see whether this is more frequent than we think it might be, you have to do what's called a nerve conduction velocity. And it's an electrical test that's actually fairly easy to do. It's non-invasive, but you stimulate a nerve up in here, for example, and then you see how long it takes for the impulse to get down to the bottom of the nerve above the ankle and to the muscles, and see whether there's loss of the signal as it goes down. But that's not been consistently studied. I'd like to see more of those done, actually. Okay, so orthopedic pathology in CFC may be primary or secondary. If secondary, it might be due to myopathy. It might be due to the encephalopathy that many of these kids get. Or it may be due to central anatomic abnormality in the brain or in the spine. There may be peripheral neuropathy, though that has never been really consistently looked at or evaluated in the CFC. Clinically, pathophysiology makes a huge difference. And I've already mentioned that knee flexion and stance may be due to weakness of the quadriceps, due to myopathy, peripheral neuropathy, or syrinx, or it may be due to hamstring contracture, which is something you see in encephalopathy. One of the dangers that you have when you go to your pediatric orthopedic surgeon is he's used to taking care of kids that are in wheelchairs because of cerebral palsy. That's all due to encephalopathy. So he's going to probably treat the patient just the way he would a kid with cerebral palsy, unless he's kind of aware that maybe CFC is different. And those treatments may not be the appropriate treatment. So the treatment does depend upon the pathology, and deformity in the lower extremities may be due to a combination of muscular weakness, peripheral nerve disease, and loss of central control. And so it becomes complex. And chemical mechanisms are slowly being defined and offering hope that some pharmacological treatments may improve outcomes, particularly for central manifestations of CFC. Somebody asked me about using Botox in the hamstrings. And I think that's probably a pretty good idea, actually. And some of these kids that are tight, I have no knowledge of that being done in CFC patients, but it would make sense to me, at least. And then, so consider the patient to be at risk for scoliosis, decreased muscle strength, flat feet, joint contractures, hip instability, and chest cage abnormalities. And now these recommendations are coming pretty much from the article that we wrote for a couple of years ago about recommendations for diagnosis and treatment. That's already been up in one of the slides in one of the general sessions. So these are coming mostly from that. At diagnosis, I think the patient should be referred to a pediatric orthopedic surgeon. I'm just going to say flat out, a standard orthopedic surgeon is going to be worthless for you. You really need a pediatric orthopedic surgeon if you're going to get any hope of getting any good results. And don't figure that the pediatric orthopedic surgeon is going to have ever heard of cardiofacial cutaneous syndrome. So if you can help him by bringing in that copy of that recommendations, that'll help a lot in getting him started. But it's easy to look up on the internet now, and you can look up about 5 major articles. He'll be in good shape. And we did write one article that is in the pediatric orthopedic literature, published in the Journal of Pediatric Orthopedics. So that's at least is fairly easily available. And then he can go off on knowing the basics of what he needs to know. And then ongoing management, radiograph of the thoracolumbar spine, pelvis, and lateral radiograph of cervical spine, depending on the clinical findings of the child. It's hard to justify doing things unless you've got something you're concerned about. But if there's concern about the hips, for example, which I think there should be in any patient that is still sitting at age 3, then I think an X-ray of the pelvis is something that I would do. I would not do X-rays of the spine unless there was curvature of the spine that I could see on the physical exam. And then for those who are not ambulatory, AP radiograph of the pelvis every 2 years to monitor for hip dysplasia afterwards. And then monitor for scoliosis clinically and do a spine MRI prior to any spinal surgery. Because and I think that's become sort of routine in spine surgery anyway. So anything other than idiopathic scoliosis is going to get an MRI before. And then ongoing management in adulthood, long-term follow-up with an orthopedist as appropriate, and this can be difficult because, again, the adult orthopedic surgeon isn't going to know anything about cardiofacial cutaneous syndrome, and so you're going to have to train another one. But at that point, he doesn't need to know about the growth problems that come in, because the child would hopefully be grown by the time he's an adult. And so an adult orthopedic surgeon is appropriate. And then keep track of the hematologic recommendations that are, bleeding tendencies are certainly there in Noonan's, but it's not something prominent in CFC. But still, I would want to get a bleeding workup before taking a patient and trying to do a total hip, for example, or a spine surgery in an adult. And see this article by Dr. Pierpont, Cardiofacial Cutaneous Syndrome, Clinical Features, Diagnosis, and Management Guidelines in Pediatrics 2014. It again is a free article available to anybody on the internet. You go to a website called PubMed, and you put in cardiofacial cutaneous syndrome, that article will pop up on there. You can click on it and then download it, and quite easily. So that's about what I have to say formally. Thank you for your attention, and then we'll leave it open to questions. Okay? So.
I don't necessarily have a question. I just want to. My son has had Botox for the last 2 years, and I have seen improvement in his ability and mobility from doing Botox. We do have to do it every 6 months.
Yeah. Right.
But it's a quick procedure, and I would recommend doing it.
Yeah, well, to me it makes ultimate sense in CFC, but you're the first one that has actually told me that had it, and so I think that's great. Thanks for sharing that. Yeah.
When you spoke about the femoral retroversion, have you found that it's typically corrected once kids start walking, even if they start walking after the age of 5?
Well, that's a good question, because when I'm talking about it, correcting, I'm talking about patients that don't have CFC, and it may well be later in kids with CFC, but a lot of kids have retroversion at birth. Once they get started walking, and they've been walking for a couple of years, it usually responds to the walking and usually goes away. I would hope that would be true of CFC, and I certainly, however, it doesn't make a huge difference if it doesn't go away. I'm going to delay treating it probably until the child is at least 10 years old. So I'm not going to cut the bones of a child that's younger than that, because it's probably going to go back. So I want to wait until the child is about 10 years old, when I've got a really good chance of cracking it without without it recurring. And it's not like they're actually walking okay, but their balance would be much better and they'd walk more efficiently if their knees were pointed forward when they're walking instead of pointed out to the side. So it's a matter, even if they're walking, I think I can improve the efficiency a lot by doing stuff like that. But it doesn't need to be done right away. Yeah.
Is there a connection between like scoliosis and the orthotics? Like, are wearing the orthotics going to help with that?
No. Now, frequently people will prescribe TLSO, thoracolumboSacral orthosis, in an attempt to control the scoliosis. And I'll just say that TLSOs have never been shown to be effective in any disease other than idiopathic scoliosis. Doesn't work in Marfan's disease, doesn't work in cerebral palsy, doesn't work in basically anything other than idiopathic scoliosis. And to me, there's no reason to think that it would be at all effective in cardiofacial cutaneous syndrome either. Orthoses below the legs, that are on the legs, have absolutely no effect on scoliosis, development of scoliosis. And that's been well studied, and it is you'll still see that in the older literature. That's something that is an effect that is just not true.
My son is almost 3, and when he sits, his spine is really curved. So the therapists always say, well, stimulate the lower back so he straightens up, and we do that, but we can't do it every time he sits. Does that mean he's going to have kyphosis, or not necessarily?
Most of the kids that are, when they get rid of that, when they're hypotonic to begin with, they're going to have that C-shaped spine that kind of bulges out, and particularly when they're sitting. And as the hypotonia goes away and and their tone gets better, and particularly as they get walking, then they'll develop a lumbar lordosis and will improve. And so I wouldn't do anything about kyphosis in that age group, other than sometimes you get these the things that they sit in, and the things that they sit in are curved. So we make a big point of making sure that the back that they're against is straight. Okay? And the other thing to say is that the first thing in my office, if I see have a patient that has, where there's a concern about that, first thing I'm going to do is flop him on the stomach and lift up over the shoulders and see whether it just flattens out. If it flattens out, I'm not the least concerned about it. Sir? I'm sorry, say that again, I didn't hear all of that.
What is the calcium level in the bones of 2 CFC children who is walking, one who is walking and one who is walking?
That's a really good question, and what he's asking is what is the bone density in children that are walking and the children that are not walking, and I'm going to guess at that. Okay, if you had 2 patients that were exactly the same, had exactly the same level of CFC, the one that's not walking is going to be significantly less bone density than the one that's walking. That's true for every other disease in the world, and I'm sure it's true for CFC too. But nobody's measured it, so. I don't think we know enough to really be able to answer that yet, really. You know, if we measure bone density then we're going to use the standards that are used for normal children, and even the standards used for normal children have just recently been developed. You know, all of the standards that were done for bone density were in adults, and it's been fairly recently that they've actually defined what it should be for a normal child that's running around. I don't think we know what is attainable in kids with CFC, and I don't think we know. You know, and traditionally, if you have 2 standard deviations below the mean, you're really prone to get fractures of the bones, and but I think that before if you can see it on X-ray, you're probably 2 standard deviations below. And we do see it on X-ray in CFC kids, but they don't get a lot of fractures.
So we've looked a lot at bone density, and I think that's one of the concerns when I look at some of the other conditions, is that the bone density appears to be low. There are multiple factors that increase your risk for low bone mineral density. One is activity, so low bone bearing activities will make your bones less dense. We haven't seen a lot of fractures in kids, but we do get concerned that if your density is low as childhood, when you become an adult, you become more risk for developing fractures because you kind of attain your maximum bone density as a young adult. And then you don't get any more bone density generally, and it just gets worse and worse as you get older. We've now seen some CFC adults that have had some fractures. And we see that significantly in Costello syndrome as well. So I think one thing we're going to now learn is as we get all of these kids that are now becoming adults with CFC syndrome, we'll start to learn more about bone density. But we don't have an exact number, and we have to go on the general population to generate these scores when we do a DEXA scan, and it's compared to the general population. We don't have any idea of whether or not it's different in CFC syndrome.
There's another aspect to that too, and that's our kids with CFC vitamin D deficient. And I know one that is, at least. And you know, a study that was done up at Scottish Rite up in Dallas showed that kids that came in just complaining of pain, they did examination on them, and they were dramatically low in vitamin D, despite living in Texas, where you would think the sun would be beating on them, and they would be making a lot of vitamin D in their skin. And that has led to a lot of looking at special populations in pediatric orthopedics. So vitamin D lack is a problem in kids with cerebral palsy. It's a problem with a lot of different special kids, and it may well be a problem with CFC too. That's something that needs to be looked at.
I do think that vitamin D is likely to be on the lower end in CFC because of a number of things. We don't know if it's biologically based, but when you have increased skin pigment, you have a decrease in the ability to convert vitamin D, and individuals with arthropathies that have more pigment. And in addition, if you're not out interacting in the sun a lot, then potentially that can also be a factor. But we really don't know. We've now seen a lot of individuals that have brought in their vitamin D levels and it's been insufficient.
I'll say one more thing, just adding on to that. Kids with CFC have gastrointestinal troubles, as you all know, and one of the things we we worry about a little bit is the ability to absorb nutrients like calcium and vitamin D from the gut. That would be another reason, perhaps, why it might be low. Yeah.
I have a question regarding my son is 9-year-old, and sometimes I wonder if there is something that we can prevent regarding his healthy bones and muscles. What would be your recommendation in order to plan a little bit ahead? I don't know if that's possible, but for example, is it a good idea to get periodically an X-ray of the spine just to see what's going on, or of the hips, or what would be your general recommendations? So that we notice what's going on with our kids regarding his health.
Yeah, generally speaking, I don't get a lot of X-rays unless there's some reason for it, really. And I don't get them routinely unless I see something on the physical examination that makes me want to do them. And these days, everybody's very concerned about radiation in kids, and I've done a lot of evaluation of that, the risk is very low, but when you start getting up to 50 and 60 X-rays in a childhood, the risk is no longer low. And so I try to avoid X-rays if I possibly can. So,
Yeah, I wouldn't recommend any screening X-rays unless there were symptoms at this point in time. There might be in the future some evidence that shows that we need to do certain X-rays. That you mentioned about hips, if there are symptoms, but those are generally if you're not walking or if there's, for example, scoliosis. I wouldn't get an X-ray for scoliosis unless on bend-over examination there was some asymmetry. But that's important to make sure that you're following up to have an evaluation with somebody who knows how to assess if there's any scoliosis or any musculoskeletal abnormality that are warrant.
I just want to say, I we can continue. If not, I just want to remind everybody the next session started already, so that you know.
So,
We'll be
thank you all for coming. We'll be around. Yeah, generally, if